Usually, when we talk about medicine, we kind of just assume a certain level of stability.
Right, yeah.
Like you go to the pharmacy, you pick up a prescription, and it sits in your cabinet for months
Yeah,
without really changing at all.
exactly. It's totally inert.
But today, we're jumping into a deep dive on a regenerative treatment where the medicine is actually, well, it's your own blood.
Which completely changes the rules.
It really does. And the paradoxical thing about these autologous therapies, meaning from your own body, is that while your blood is packed with these incredibly powerful regenerative factors, a microscopic countdown clock begins the absolute second it leaves your vein.
Yeah, and what's fascinating here is that it is a biological ticking clock in the truest sense of the word.
Right.
Because you're taking living, highly reactive cells out of their natural systemic environment, and you're basically forcing them into a state of panic.
A microscopic panic attack.
Essentially, yes. And every single minute that passes, and honestly, every degree of temperature fluctuation dictates whether those cells will successfully regenerate tissue or just, self-destruct in a test tube before they ever even reach their target.
And that countdown is exactly the mission of our deep dive today. We are exploring the science of platelet-rich plasma, or PRP, specifically looking at how it's used in the O shot.
Which, for those who might not know, is a regenerative procedure targeting women's sexual wellness.
Exactly. And we've pulled from a pretty diverse stack of sources for you today. We've got clinical guidelines in cosmetic dermatology, some orthopedic research papers, actual blood banking manuals, and the highly specific clinic protocols governing the O shot itself.
It's a lot of ground to cover.
It is. But our goal here is to extract the exact shelf life and thermal stability thresholds of freshly prepared autologous PRP. We want to track down exactly how long providers have before this biological material goes bad and the physical rules governing that specific window.
Because the clinical reality of PRP is honestly far more complex than the whole magical elixir marketing often suggests.
Oh, absolutely.
We are dealing with really volatile biochemistry here. It requires an incredible level of environmental control because these platelets are practically desperate to do their job.
They want to heal things immediately.
Right. And if the clinic doesn't manage the physical parameters perfectly, those platelets will just initiate their healing cascade at the wrong time in the wrong place.
Okay, let's unpack this by grounding it in the procedure itself before we even look at the timeline.
That makes sense.
So the O shot involves drawing a woman's own blood, that autologous blood we mentioned, then spinning it in a centrifuge to isolate the platelet-rich plasma.
Usually takes, what, about 15 to 30 minutes for the core procedure?
Yeah, the whole appointment might be closer to an hour, but the actual injection goes into the clitoris and the anterior vaginal wall, essentially the G-spot area.
Right.
And the clinical goal here is utilizing the growth factors housed inside those platelets to stimulate collagen production, trigger angiogenesis, which is new blood vessel growth, and promote nerve regeneration.
Primarily to treat things like sexual dysfunction, loss of sensitivity, or urinary incontinence.
Right, exactly. But here is the critical part about the activation.
Oh, this is the most important piece of the puzzle.
Right. For the O shot, the clinician wants a massive localized activation of those platelets, but only after they're actually delivered into the tissue.
And exactly after, not a moment before.
This is why the protocols often involve adding something like calcium chloride just prior to the injection, right?
Yep.
To trigger the formation of a platelet-rich fibrin matrix.
Yeah, you add the calcium chloride and it forces the platelets to clot and release their payload right there in the tissue.
And just to note, the sources explicitly mandate avoiding anticoagulants like heparin.
Oh, yeah, you definitely want to avoid heparin because that would inhibit this necessary localized clotting cascade. You need that clot to form.
Okay, so think of these platelets like tiny microscopic water balloons filled with fertilizer.
I like that analogy.
You want those balloons to burst inside the garden, the vaginal and clitoral tissue. You absolutely do not want them bursting in the bucket while you are carrying them from the hose out to the garden.
Right, because if they activate prematurely in the syringe or in the test tube, they degranulate.
Degranulate meaning they burst.
Exactly. They basically just dump their platelet-derived growth factor, their vascular endothelial growth factor, and transforming growth factor beta, all of it, directly into the surrounding plasma right there in the tube.
Oh, wow. So they just spill all the good stuff into the bucket.
They do, and those signaling molecules degrade really rapidly once they're released.
So by the time that fluid is actually injected,
It's totally biologically exhausted. It's useless. It can't stimulate the stem cells or repair the mucosal tissue because the chemical instructions have already just dissipated.
but knowing that those balloons can burst early has to create a massive logistical headache for clinics.
Oh, it's a nightmare for standardization.
I mean, if drawing the blood starts the timer, how long do they actually have before the payload is ruined?
Yeah.
Because the medical literature we reviewed on this is wildly fractured.
It really is. And I think it reveals how different medical disciplines define the word viable. You're looking at vastly different clinical endpoints depending on the specialty.
Well, let's look at cosmetic dermatology. Their guidelines are honestly kind of draconian about this.
They are very strict.
They state the maximum time period between blood collection and application should not exceed 1 hour, period.
1 hour.
But then you look at orthopedic and general blood banking consensus papers, and they argue PRP is stable for clinical use for up to 4 to 6 hours post-preparation.
Assuming it's kept at room temperature. Yeah.
Right. And then there's this study by Shen et al. Observing premature platelet activation, which basically mandates use within 24 hours to minimize what they call the platelet storage lesion.
Yes, the storage lesion.
I mean, if I'm a patient sitting in a clinic waiting for an O shot, a 23-hour variance in medical opinion is a little concerning, you know?
It is, but to reconcile that discrepancy, we really have to look at the mechanics of that platelet storage lesion you just mentioned.
Okay, break that down for us. What is the storage lesion?
So when platelets are isolated from your circulatory system, they don't just sit there passively in the tube.
They're still active.
Very active. They continue metabolizing, primarily relying on glycolysis. And this metabolic process produces lactic acid as a byproduct.
Right, like when you work out and your muscles burn.
Exactly the same concept. But inside a sealed test tube, that lactic acid accumulates and it causes the pH of the plasma to plummet.
It gets highly acidic.
Right. And as the environment becomes increasingly acidic, the actual physical structure of the platelet membrane begins to break down.
Oh, so they're basically swimming in their own toxic waste.
Yeah, that's a great way to put it. This metabolic exhaustion and structural degradation is what we call the platelet storage lesion.
So that 24-hour surgical rule from the Shen study is essentially operating on the absolute outer limit of that degradation.
Correct. By 24 hours, you have significant morphological breakdown. I mean, massive premature activation has already occurred.
So why would anyone use it at 24 hours?
Well, in broad surgical applications, like, say, packing a large bone graft in orthopedics, a slurry of partially degraded platelets might still offer some physical scaffolding utility.
Okay, that makes sense for bones. But what about the 4 to 6 hour rule?
So the 4 to 6 hour mark is generally accepted as the biochemical cliff for living cell viability. Beyond 6 hours at room temperature, the functional integrity drops off so severely that you just can't rely on the regenerative signaling anymore.
Which kind of isolates that 1 hour rule as the true gold standard for delicate, highly vascularized tissue.
Absolutely. Especially for mucosal tissue.
Because in the O shot, you're injecting the clitoral complex. You need maximum biological signaling.
You want peak efficacy.
Right, which means zero tolerance for that lactic acid buildup or premature degranulation.
And that's why efficiency is so key. The best clinic protocols outline this really seamless process. Blood draw, centrifuge, local anesthesia, and injection, all entirely contained within a single 45-minute continuous visit.
So the 1 hour rule guarantees the platelets haven't entered even the early stages of metabolic exhaustion.
Exactly. You're capturing them at their absolute peak.
But time is only one dimension of this countdown, right? Because the rate at which that metabolic exhaustion occurs is entirely dictated by temperature.
Oh, temperature is the silent killer here.
Yeah. The American Association of Blood Banks Manual sets the baseline recommendation for centrifuging blood to obtain PRP at room temperature, which they specifically define as 21 to 24 degrees Celsius.
Which sounds completely straightforward, right? Until you look at the thermal sensitivity of the lipid bilayer in the actual platelet membrane.
And here's where it's really interesting. The Mars-Furtis study highlights exactly how sensitive that membrane is.
It's shockingly sensitive.
Right. They found that incubating platelets at exactly 22 degrees Celsius, which is right in the middle of that room temperature range, actually caused morphological changes.
Yep. The shape changed,
The platelets morphed from their normal resting discoid shape into a spherical shape.
which is the primary physical indicator of activation.
And a secondary analysis showed that fresh PRP has a baseline activation rate of around 3.6%. But if you leave it out overnight at room temperature, it jumps to 16% premature activation.
So I'm sitting on a counter.
Yeah, just sitting in an ambient room accelerates the degradation.
And if we connect this to the bigger picture, this exposes a major hidden variable in how clinics actually prepare this material.
The centrifuge.
Exactly, the mechanical reality of the centrifuge.
Because spitting blood at thousands of revolutions per minute generates immense mechanical friction.
it creates a lot of heat.
So if the room is sitting at 22 degrees, the inside of a standard, non-temperature controlled centrifuge rotor is going to heat up well past that safe 24-degree threshold.
The equipment used to isolate the medicine is actively cooking it.
Wow, that is wild.
It induces acute thermal stress. When the ambient temperature around the platelets rises, it destabilizes the proteins embedded in their cell membranes.
And how do the platelets react to that?
Well, the platelets interpret this structural destabilization as cellular damage.
Oh, they think they're under attack.
Basically, yeah.
No.
And that triggers their internal survival and activation pathways. So they abandon their resting discoid shape, turn spherical, and begin prematurely spilling their growth factors in the tube.
Just because of the friction heat from the centrifuge.
Right. This is why high-end clinical protocols for the O-shot absolutely insist on temperature-controlled centrifuges. They specifically use them to offset that friction heat, basically chilling the rotor just enough to keep the microenvironment locked safely below 24 degrees.
Okay, so if ambient room temperature and friction heat cause this kind of thermal stress and premature activation, the immediate logical leap, at least for me, is cold storage.
Oh, this is my favorite part of the date.
Right. Because if I want to stop the metabolic clock and prevent the platelets from exhausting themselves, I should just put the PRP in the refrigerator. Just chill them out.
It makes intuitive sense.
But the sources reveal a bizarre biological paradox when you actually drop the temperature.
The cold storage paradox. It fundamentally challenges our intuitive understanding of how cells react to chilling.
Yeah, wait, so the data shows that short-term refrigeration, like dropping the PRP down to 2 to 6 degrees Celsius for just 1 to 2 hours, does not put the platelets into metabolic hibernation.
No, not at all.
It actually actively enhances their responsiveness. Like, the studies say it attenuates their inhibitory signaling, boosting their reactivity to collagen by 30 to 40%.
It makes them hyperreactive.
Wait. So making them cold for an hour actually makes them substantially more explosive and primed to clot.
Yeah.
That seems so counterintuitive.
It does, but to understand why cold acts as an activator rather than a sedative, you have to look at the fluid dynamics of the cell membrane.
Okay, take us to the microscopic level here.
So the platelet membrane is made of lipids, fats, essentially.
Right.
And think about what happens to fat when it gets cold, like bacon grease in a fridge.
Oh, it hardens up.
Exactly. When you drop the temperature rapidly, those lipids start to solidify. They undergo this phase transition from a fluid state to a gel-like state.
Okay, I'm with you.
And as the membrane stiffens, the various protein receptors that normally float freely around in that membrane are forcefully clustered together into these tight little groups. We call them lipid rafts.
So the cold is physically crowding the receptors together on the surface of the cell.
Exactly. And the platelet's internal signaling network totally misinterprets this sudden clustering of receptors as a massive activation signal.
Oh, it thinks it's time to go to work.
Right. It downregulates cyclic AMP, which is the molecule that normally acts as the biological brakes, keeping the platelet calm. And suddenly you have a cell that is hyperreactive, twitchy, and just primed to initiate a massive clotting cascade the microsecond it encounters tissue collagen.
Which, I mean, sounds like a good thing if the whole goal of the O-shot is massive localized clotting and growth factor release. You would think clinicians would want hyperreactive platelets, right?
Well, not while they are still in the syringe.
Right.
If you have hyperreactive platelets, the sheer mechanical stress of just being pushed through the needle, and these are very fine gauge needles used for mucosal injections, that mechanical stress alone can trigger them.
So they would just clot inside the needle.
They will literally clog the needle, or they'll degranulate during the transit through the needle rather than in the tissue itself.
Which ruins the whole procedure.
Completely. You need them completely stable until they are safely deposited into the target zone. Therefore, fresh, immediate room temperature injection remains the absolute gold standard over any short-term chilling.
But that dynamic completely flips when we look at long-term cold storage data, doesn't it?
It does, which is where things get even more interesting.
Yeah, because standard refrigeration at 4 degrees Celsius works exceptionally well for things like PRP eye drops. The studies show they can be stored this way for up to 4 weeks.
And they maintain higher levels of growth factors than standard serum while remaining totally sterile.
And deep freezing genuinely stops the clock.
Yes, deep freezing is a whole different ballgame.
The sources mention PRP freezes stably at minus 20 degrees Celsius for 3 months, or it can be cryopreserved at minus 40 degrees Celsius, which is actually validated for up to 12 months.
And those canine PRP studies really prove this out. They demonstrated that storage at minus 20 degrees preserves the platelet count and prevents microbial contamination exponentially better than standard 4-degree fridge storage.
So what's the difference? Why does an hour in the fridge make them explode, but months in a deep freeze keeps them perfect?
The difference lies entirely in the severity of the cold. Short-term chilling at 4 degrees alters the membrane just enough to agitate the signaling pathways.
It just stresses them out.
Exactly. But deep freezing at minus 20 or minus 40 degrees induces a complete halt of cellular metabolism. The glycolysis stops, the lactic acid production stops.
Everything just pauses.
Right. So for clinical applications like, corneal wound healing, where a patient needs daily biological eye drops, or maybe staged orthopedic interventions over several weeks, freezing is highly effective.
But managing a deep freeze cryopreservation protocol for a single session, on-demand procedure like the O-shot is just logistically unfeasible for most fast-paced clinics.
Oh, it would be a nightmare.
You'd have to draw the blood, freeze it, thaw it safely without rupturing the membranes, and then inject it. It completely defeats the efficiency of a 45-minute appointment.
Which is exactly what drives the need for an alternative method of pausing the biological clock. Something that offers the stability of deep freezing, but without the massive logistical burden of managing cryogenic freezers in an outpatient clinic.
And that brings us to our final source topic, lyophilization.
Freeze drying.
Yeah. It sounds like absolute science fiction, but the research points to this as the mechanism that could completely detach PRP from its strict 1-hour biological countdown.
And this raises an important question about the future of medicine, really, because lyophilization fundamentally shifts the paradigm of regenerative therapies. You are transitioning a highly volatile living cellular therapy into a stabilized, completely inert state.
But the challenge with freezing any cell, as we read in the literature, is that water forms ice crystals.
And ice expands.
Right, and those microscopic ice crystals act like tiny daggers, just shearing the cell membrane from the inside out when you freeze and thaw them.
That's the hurdle, yes.
But according to the research, lyophilization circumvents this by removing the water entirely while preserving the structural integrity using a non-toxic cryoprotectant called trehalose.
Trehalose is such a fascinating molecule.
How does it work?
It essentially steps in to replace the water. So as the water is sublimated away during the freeze-drying process, the trehalose forms hydrogen bonds with the proteins and lipids in the platelet membrane.
So it's basically holding the walls up.
Exactly. It creates a highly stable, glassy matrix that props up the cellular architecture, completely preventing the proteins from collapsing in on themselves as the fluid vanishes.
That is incredible. So the end product is literally a stable PRP powder.
A shelf-stable powder.
Now, the studies do indicate a slight trade-off here, right? The lyophilization process does cause a moderate reduction in certain growth factors.
Yes, specifically PDGF and VEGF when you compare it to freshly drawn liquid PRP.
However, the critical takeaway from all these sources is that it retains its functional regenerative capacity. Like, in clinical testing, this reconstituted powder successfully promoted cell viability, wound closure, and angiogenesis.
Because even with the moderate attenuation of those specific growth factors, the remaining biological payload is still robust enough to drive extracellular matrix remodeling.
And the implications of that are profound for a procedure like the O-shot.
Huge implications, because right now, autologous PRP is a deeply inefficient process. I mean, you draw the blood, you battle the clock, you mitigate the centrifuge friction, and you have to inject immediately.
It's a sprint.
It really is. But lyophilization allows expired or leftover platelet units from blood banks to be pooled, sterilized, freeze-dried, and stored indefinitely at ambient room temperature.
So a provider can literally just take a vial of this freeze-dried powder off a shelf, reconstitute it with ultra-pure water, and it instantly forms the necessary gel and releases the regenerative factors, just like fresh autologous PRP.
It transforms a hyper-personalized, super time-sensitive procedure into a standardized, quality-controlled pharmaceutical product.
It eliminates the variables. The clinic is no longer racing against lactic acid buildup or worrying about a warm centrifuge activating the platelets. The biological clock is permanently paused until the exact moment of reconstitution.
Which is just a massive leap forward for regenerative medicine.
Absolutely. So, synthesizing all of this, for anyone navigating these therapies or getting an O shot, the shelf life and thermal stability of fresh autologous PRP is incredibly fragile.
Extremely fragile.
For a successful O shot, the blood must be centrifuged carefully, managing friction to keep the internal temperature strictly between 21 and 24 degrees Celsius.
Yes.
The material must be injected ideally within 1 hour and absolutely, without question, before 6 hours to ensure those growth factor payloads don't degrade in the tube due to metabolic exhaustion.
Right. Avoid the platelet storage lesion.
And short-term refrigeration will only make the platelets hyperreactive and difficult to inject safely.
Yeah.
So every single step in the lab handling is honestly just as critical to the regenerative outcome as the injection technique itself.
It really demands an immense amount of precision from the provider. You are weaponizing the body's own biological mechanisms, and those mechanisms operate on a very strict, very unforgiving timeline.
And you know, that timeline is exactly what makes the lyophilization data so compelling to think about.
Oh, for sure.
Because I was just thinking, if we can now successfully freeze-dry platelets into a shelf-stable powder using trehalose without destroying their regenerative capacity, we are looking at a fundamentally different future for healthcare.
How so?
Well, what is to stop us from proactively banking our own young, highly viable platelets in our 20s or 30s?
Oh, wow.
Imagine walking into a clinic decades from now, pulling a vial of your younger self's freeze-dried cells off a shelf, reconstituting them, and using them for an O-shot or to repair a failing joint when you're 60.
That's a wild thought, biologically pausing your own youth.
Right. We spend so much time searching for external solutions to aging, but the real fountain of youth might just be our own biology, waiting patiently in a freeze dryer.
That's incredible.
It really is. Keep learning, keep questioning, and we will catch you on the next deep dive.